Good afternoon to everyone. We are going to start to keep at least near the time. A lot of countries and all talking about complications, mostly of sleeve gastrectomy and OAGV. I think OAGV is taking a space in our strategy for treating obesity. So let's get started with all these interesting cases. First, Dr. Paula Richman from Austria, pulmonary fibrosis due to silent aspiration after one anastomosis gastric bypass, a case report.
Thank you very much for the introduction. Good afternoon, everybody. I am really happy to present you a case report which might be interesting for most of you. I have no conflict of interests. I'm just really quickly talking about OAGB in general because I saw that other colleagues after me will go deeper into that topic. Just to conclude, it's a well-established bariatric procedure with excellent outcomes. And nevertheless, there are complications, and the most common causes for revisional surgery are persistent ulcers, malnutrition, and bile reflux, which is important for this case presentation. Talking about reflux, for GERD in general is associated with pulmonary diseases. That's quite well known. In patients with lung fibrosis, up to 76% report GERD, but there is no data available on patients with reflux after OAGB and de novo lung diseases. So coming to my case presentation, there was a 37-year-old woman with a BMI over 40. Other than depression, there were no other comorbidities. She didn't report to have any symptoms of reflux. Also in the gastroscopy, there were no signs for GERD, no hiatal hernia, so we planned her for OAGB. The surgery went fine without any intraoperative complications. Also, the post-operative course was uneventful, and we discharged her on the third post-operative day, which is the common discharge day in our clinic. The first post-operative consultation was a little bit later than usually. Usually the patients come back 3 months after surgery. This patient had a spinal cord injury, and that's why she came back later. And she was really happy with the weight loss. She had an excess weight loss of 112%, now weighing 62 kilogram body weight. But she reported to have symptoms of reflux now. We prescribed PPI and instructed her to strictly abstain from smoking because she was a heavy smoker. And we suggested endoscopy. What happened next? The patient never came back. Fast forward 10 years later, our patient reported to a pulmonology department. And now with dyspnea, hemoptysis, she really didn't feel well. And this was the CT scan you can see with ground glass opacities really not looking very well. As the patient was a heavy smoker, also persisting reflux, it was important to know that the patient received gastroscopies at a gastroenterologic outpatient department, but she was never admitted to a surgical unit, so no surgeon saw her in the last 10 years. At the pulmonology department, they did immunological assessment, came back negative. Also, malignancy-associated causes, everything came back negative. Infectious reasons also without any cause to find. The patient felt worse and worse, and 3 months later, another CT scan was performed where there were even worse images. So a bronchoscopy was performed, and this is these are the pictures that were found with a lot of bile in the trachea and also in both main bronchi. And the biopsy result showed peribronchial fibrosis. So then finally she was admitted to our unit, and we planned prioritized conversion to Roux-en-Y gastric bypass. This is how we do it. And 6 months after surgery, she came back to the pulmonology department for a consultation. She felt way better. She reported complete remission of reflux and improvement of dyspnea. And also in the CT scan, you can see that the pictures improved quite well. So I'm already coming to my conclusion. Post-OAGB pulmonary complications should be included in the differential diagnosis for de novo lung diseases. And therefore, I think it's really important to raise awareness among other specialties, especially pulmonologists or also gastroenterologists, that this can be a complication of OAGB. And obviously, a conversion to Roux-en-Y gastric bypass should be planned very fast to avoid progression of the lung disease. Thank you very much, and I hope to see you all in Vienna next year for the European chapter IFSO. Thank you.
So we're going to make questions or comments at the end of your presentations, all presentation. So the second presenter is Dr. Johannes Sander from Germany. Is one anastomosis, gastric bypass, and biliary reflux, frequency and therapeutic options after 2713 primary procedures. Please, welcome.
Yeah, thank you very much for the introduction. I can have the slides, please. Yes, thank you. Very interesting talk from Vienna, because 2 of the patients I'm reporting of really suffered from pneumonia due to nightly. 2 of our patients suffered from pneumonia due to nightly bile reflux. So just let me show our data. I have no conflicts of interest to declare. This is my case mix disclosure. We all know that bile reflux is a common finding after OAGB. But as Dr. Prager and his group showed a couple of years ago, only a small number of patients develop clinically significant reflux, bile reflux, which leads to revisional surgery. But when it comes to revisional surgery, then bile reflux is clearly the main underlying cause of reoperation. Coming to our own data, in between 6 years, from September 16 to September 22, we operated 2,713 primary OAGBs in our department. The mean BMI at operation was 49 and the average age 42 years, and we predominantly operated on women. This is our standard procedure. We made a tailored biliopancreatic limb of 150 to 200 centimeter. Luckily, we have very few complications. For example, the leakage rate is only 4 out of these patients. Coming to bile reflux, 47 of our patients needed revisional surgery due to refractory bile reflux up to December 22. Quick look into the patient data. The initial BMI of these patients was a little bit lower than the average, only 47, but the initial age at the point of the primary operation was 4 years higher than the average, 46 years. Maybe that can explain a little bit. The time from primary procedure to revisional surgery was on average 34 months, with a relatively wide span from 1.5 months to 64 months. And if we look a little bit deeper into our data, bile reflux is really, the development of bile reflux seems to be clearly a matter of time. If we look to our patients we operated on in 2016 and 17, the revision rate is climbing up to 5.9 to 7.4%, but I'm happy to discuss this later on. The indication for revision surgery was biliary reflux alone in 63 of our patients, and in these patients we did a distalization of the biliary limb, which creating a Roux-en-Y situation with an elementary limb length of at least 50 centimeter. And if concomitant gastric ulcer was observed, that was the case in 11 of our patients, then we revised the gastrogenostomy as well. The average operation time was 63 minutes for the distalization alone and 122 minutes for the revision with gastrogenostomy, which we usually do with a hand-sewn anastomosis. Early complications were very rare. We only see some one hematemesis, some bleedings at the JJ site, and 2 abdominal wall hematomas. Coming to our results, only 2 patients suffered from slightly excited reflux in the long term, which was perfectly controlled under the use of PPI. A newly diagnosed dumping syndrome was observed in 1 patient, and 4 patients developed another anastomotic ulcer, which was treated under medication. And what we expected, the remission of biliary reflux was 100%. Thank you.
Now we have 3D CT scan conduit and esophageal metrics, a valuable method to diagnose post-sleeve gastrectomy angularis stenosis. Sam Alayo from Australia.
Hi everyone, Sam here from St George Hospital from Sydney, Australia, and presenting our project as you can see here and read on the screen. So I have no disclosures. Now, sleeve gastrectomy, as everyone knows, is a great operation, but reflux and weight regain is real. Reflux is multifactorial, as we've heard throughout the conference. It can be related to esophageal motility, it can be the hiatus hernia, but it can also be secondary to the sleeve configuration, and stenosis is reported to be in up to 4% of patients post-sleeve. So reflux is one of the most common indication for revisional bariatrics, and revisional bariatrics comes with their own risks and their outcomes as well that can be unpredictable. So we really do assess patients thoroughly because we believe that it's important to get them the best results, and there are multiple tools. Some of them, like all of them, got their ups and downs really. In our center we routinely do 3D CT scans because we believe that in addition to volumetry and the diagnosis of hiatus hernias, we actually can be able to identify sleeve configuration and whether there's any stenosis on CT scan or not. In order to understand why it's important that we talk about 3D CT scan measurements and configuration, we're going to talk about some of the laws that govern the movement of fluids in vessels in our body. So there are Laplace law and Poiseuille's law. Essentially, with the top one, Laplace law, if you've got 2 chambers of similar wall tension, the smaller chamber will exert more pressure. So if there's fluid in the smaller chamber, then that fluid will move in an upward direction towards a larger chamber. And if there's in Poiseuille's law, it's a relationship between the radius and the pressure within a vessel. So a smaller radius means a higher pressure, approximately an impedance of flow of fluid. So we think that in a sleeve stomach, if it's angulated, kinked, or stenosed, then there'll be impedance of flow, which will create higher pressure and will create proximal tension, stretching out of the conduit and lengthening, and over time they'll have reflux symptoms. This is what we do for our 3D CT scans. This is how we assess them. These are the measurements on the left-hand side, and on the right-hand side you could see some pathological pictures of a sleeve that we've assessed. And you could see that there's disparity in the top two images, so even if those patients had hiatus hernias, you can be assured that if you fix the hiatus hernia alone, they're not going to get better. So, our primary objective was to establish if the 3D CT measurements correlated with stenosis in an approach to standardize how we assess sleeves on 3D CT scan, and also as a secondary outcome of whether there's any measurements that can predict outcomes of revisional surgery. So we have identified 64 patients retrospectively who had sleeves and also came in with symptoms and ended up having 3D CT scans. All the 3D CT scans were performed in the same center, reported by a radiologist, and measurements were performed by the research team. And the patients' demographics and results are as follows. Just a very quick picture. The majority were females, as you can see. And we dichotomized them into two groups, endoscopy findings and symptomatology, how they presented. The majority of people presented with reflux and regurgitation, but surprisingly only 9 patients had actual evidence of stenosis and or severe reflux on endoscopy. Now this is the real deal. Did the 3D CT images finding corroborate with the endoscopy findings? And what we found is that yes, for those who had stenosis and reflux, they had lower volumetry, they had lower angularis cross-section, they had lower distal cross-section, and also they had a lower ratio between the angularis cross-section and proximally, and particularly a ratio of 0.5 or less indicated stenosis. So these are really big words and big things, so I'm just going to translate them to what really they mean. And it means that the esophagus dilate and the sleeve elongate over time in patients with smaller angularis cross-section. In addition, so it means if you see a disparity between the angularis and proximal sleeve, it means that you're likely dealing with stenosis. So we looked at, of those cohort of patients, 27 actually had revisional surgery, and we looked at the bypass and stricturoplasty patients and which people did better. And we found that if they had a 0.5 ratio or less between the angularis cross-section and proximal conduit, those patients done better. So this is the first study that we know of that describes specific 3D CT measurements and its association with the stenosis and predictors of outcomes. Also, we believe that with our study that measurements did correlate with endoscopic findings of stenosis, and they did predict somehow outcomes in that cohort of patients. We did have limitations. It's a retrospective study. There's lack of asymptomatic cohort, but we believe that if we work on a prospective study, then we'll be able to provide probably similar results, but better results as well. Thank you.
Now we move to Luis Enrique Capaverde from Brazil. Is going to give a presentation about gastrin producing G cells in the gastric pouch of Roux-en-Y gastric bypass and the relationship with the occurrence of marginal ulcers. Please.
Good afternoon. My name is Luis Henrique. I am breast surgeon from Brazil. And I'm going to talk about a very important subject that is marginal ulcers and how gastrin producing G cells could be related to them. I have no disclosures. Well, marginal ulcers are a break integrity of GJ mucosa. They can occur, they are the most prevalent post-op EGD abnormality, occurring up to 16% of patients. 30% can be asymptomatic, but when symptomatic, they can experience pain, vomiting, bleeding, and even perforation. Several factors have already been described as causative agents, which means it's a multifactorial disease. One of the most studied factors is the pouch size and the acid production. When talking about acid production, we have one of the most studied causative agents. As in this study made by IFSO, they perform a volumetric study in the gastric pouch using CT scan, and they observed that an increase in the pouch size increased the chance of marginal ulcer because we are retaining a great amount of acid production mucosa within the gastric pouch. When we are thinking about acid, we have to think about gastrin. Gastrin is produced by G cell located in the antrum and will induce the parietal cell located in the body and the fundus to release acid. When we perform a gastric bypass, we lose the enteral stimula of food. That is, we have a decrease in the serum level of gastrin. But you might be wondering, why look for gastrin-producing G cells in the gastric pouch if the cells are located in the antrum? We also know that we have a transitional zone located at the level of incisura angularis, and it can stand above incisura angularis. And this zone can contain a mix of both antral and body fundic glands. And this is the zone we believe is at the risk to be included within the gastric pouch when performing the first horizontal stapling. We didn't find this answer in literature. No previous study evaluating the presence of gastrin-producing G cells in the gastric pouch. So we decided to look. We delineated a case control study where we perform histological evaluation of gastric pouch through biopsies collected by endoscopy. And we look for density of gastrin-producing G cells and also density of parietal cells. This is the population of our study. We evaluated 1,104 Roux-en-Y gastric bypasses performed between 2010 and 2020 by the same group. About half of those patients didn't perform follow-up EGD, so we could not evaluate them. And from those who performed follow-up EGD, 23 patients had marginal ulcers, which accounts for 4% of incidence in this population. After applying the exclusion criteria, we had 19 patients with marginal ulcers, and we compared them with 38 controls extracted from the same population. This is our groups. They were very similar. We had more men in the marginal ulcer group, and we had a lower BMI in the marginal ulcer group. Our staining was very positive for gastrin-producing G cells in some patients, and then we perform a comparison between patients with and without marginal ulcer, and we did find higher incidence, higher density, statistically higher incidence of gastrin-producing G cells in the gastric pouch of patients with marginal ulcer. This is the graphical comparison between the density of parietal cells. We didn't find difference. So, for conclusion, marginal ulcer is a multifactorial pathology that's still generating morbidity to our patients. In our study, marginal ulcer group presenting higher density of gastrin-producing G cells in the gastric pouch. G cells retained in the gastric pouch could remain susceptible to food stimulus. And I want to finish the presentation with this graphic that represents how marginal ulcer is a complex pathology, and we have several pieces of puzzle that remains unsolved. And with our study, we believe that G cells and gastrin may play a role in this complex puzzle. Thank you very much.
Now we continue with prevalence, indications, and complications of conversional surgery after vertical banded gastroplasty. MBSA QAP analysis. Juan Barajas Gamboa.
Good afternoon, everybody. First of all, thank you for this great opportunity to present our work. I'm from Cleveland Clinic, Abu Dhabi. I have no disclosures for this presentation. And as you probably know, vertical banded gastroplasty was a very popular surgical procedure back in the 80s. However, with the pass of the time, it lost a lot of popularity due to several reasons. The first one was the poor long-term weight loss in those patients. Second, the patients experienced a lot of complications that were related to the surgical technique. And in parallel, at that time, other surgical techniques, such as sleeve gastrectomy and Roux-en-Y gastric bypass, started showing better results, so surgeons switched the surgical practice. Up to date, there is still limited data on outcomes for conventional vertical banded gastroplastic to other surgical techniques. This is a very new topic that now we have the opportunity to explore, having the database, the MESQUI database, including revisional surgery cases. Having said that, the objective of this study was to determine the prevalence, the indications, the rate of 30-day serious complications, and the mortality of conventional surgery after vertical banded gastroplastic. For the methodology of this study, we conducted a retrospective study that includes 30-day outcomes from more than 900 centers around the world, and the population that we target to analyze were individuals undergoing conventional surgery after vertical banded gastroplastic. As a part of the inclusion criteria, we have cases that were performed laparoscopically and robotically. And second, as all of you know, the data that is reflected in this database regarding the revisional surgery started back in 2020. So for this study, we limited to 2020 and 2021, the data that was available at that time. The major outcomes that we wanted to evaluate in this study were the rate of serious complications and the mortality for conventional surgery after the initial procedure. And the statistical model that we used was a multivariable logistic regression to determine the factors that were associated with serious complications as well as the mortality rates. In this cohort of patients, we found that a total of 486 vertical banded gastroplastics occurred in this period of time. And curiously, the most common procedure that those patients had after their conversion included Roux-en-Y gastric bypass, representing 83%, followed by the sleeve gastrectomy, single anastomosis gastric bypass, biliopancreatic diversion and duodenal switch, and other procedures. Having said that, we noticed that more than 87% of the population of those cases had either Roux-en-Y gastric bypass and sleeve gastrectomy. And because of that, we decided that the remaining analysis of this study was only including the patients who had conversions to Roux-en-Y gastric bypass and sleeve gastrectomy. Here in this table, we are representing the characteristics of these patients. So as you can see, most of those patients had Roux-en-Y gastric bypass. The distribution of gender is quite similar among these two groups, and the body mass index, the BMI, at the beginning of before the conversion in the Roux-en-Y gastric bypass group was most common between 40 and 49 in comparison with the sleeve gastrectomy. That group had most of the cases between 35 and 39. The American Society of Anesthesiologists class was very similar in both groups. And in terms of diabetes, it's very particular to see that patients who had a sleeve gastrectomy were likely to have more insulin-dependent diabetes in comparison with the Roux-en-Y gastric bypass group, who had more prevalence in non-insulin cases. In terms of comorbidities of those cohort of patients, we found that hypertension, GERD, and hyperlipidemia were the most common diseases that were associated with this main disease. For the indication of the surgery, we found that weight gain, gastroesophageal reflux disease, and inadequate weight loss were the most common indications for surgery in those groups, including Roux-en-Y gastric bypass and sleeve gastrectomy. And we found very important data regarding the length of the surgery. In the Roux-en-Y gastric bypass group, the mean post-operative time was 23.6 minutes in comparison with 132.3 in the sleeve gastrectomy. For the analysis of complications and mortality after the conversions, we found that the most common complications were leaks, followed by bleedings, and deep surgical infections. So even though those complications were not statistically significant, it's very important to highlight that the data that we found here is compared with other studies that have been published in this field. Finally, we found a very high serious complication rate in the Roux-en-Y gastric bypass group, representing 15.7% in comparison with only 7.3% in the sleeve gastrectomy group. We believe that is because the surgical technique and the level of complexity. And finally, we found a higher mortality rate in the Roux-en-Y gastric bypass group, representing 1.2 versus 0%. In regards of the significant risk factors for serious complications, when we did the multi-regressional analysis, we found that chronic obstructive
30 seconds.
pulmonary disease was associated with increase of mortality as well as longer operative time. Study limitations, the data is limited to only 30 days. We didn't have concurrent procedures data, that is probably not captured correctly, the lack of granularity in comorbidities. And finally, there is a heterogeneity in surgical techniques and approach that it depends on the surgical group. In conclusion, we found that conversion surgery after vertical gastric bypass is uncommon only with 480 procedures. The risk factors are more common with pulmonary diseases and longer operative time, and patients at the end should be informed about those risks prior to undergoing conversion surgery. Thank you so much for your time.
Now we have Dr. Georgios Geropoulos from UK, portal mesenteric vein thrombosis in patients undergoing sleeve gastrectomy, a meta-analysis of 100,086 patients. Dr. Geropoulos is not here. Well, we move on to Dr. Gaël Gouyan from France. Serious complication after revisional bariatric surgery, national retrospective study from the French National Database.
Hello, good evening. Actually, I'm not Dr. Gouyan, but he's my fellow, so he had to stay home to work in order to permit me to come to Naples. So this is going to on all alone. Okay. So I'm very glad to be here to discuss with you about serious complication after a revisional surgery in France. And these are my disclosure. And this is my clinical practice. Revisional procedures are becoming more and more present in our surgical activity in France. It is estimated that about 13% of bariatric procedures are revisional in France, which means that 1 patient out of 7 has been already operated on when goes to the operating theater. But when we say revisional procedure, there's a lot of things behind these terms. Until 2016, 76% of revisional procedure was revisional after gastric banding. And we had only 20% of revision after sleeve. And at the time, revision after bypass was very rare. But things have changed. Believe me, things have changed. Things have changed because last year, revisional surgery after sleeve has started to overcome revisional surgery after banding. And then you can see a revisional procedure after bypass are growing up. They remain not uncommon, but they are growing. So if the type of revision is changing, what is the impact on complication rate? So we went back to our, we have a national court built on national discharge database, which is comprehensive of all hospitals, private and public in France. And so we went back to look at the results of all adult patients operated between 2016 and 2022. And our main outcome was to assess major complications at 90 days after surgery. Major complications, as often, are considered the Clavien-Dindo classification, 3, 4, and 5. 3, as you know, is reintervention with or without general anesthesia. 4 is an intensive care unit stay, and 5 is death. So without surprise, primary surgery has less major complication than revisional. It goes from 3.2 to 6.0%. And when we consider in adjusted analysis all the other confounders, the odds ratio is 1.53. It means that revisional surgery has 53% of complication more than primary surgery. And this is just to begin with. When we stratify in function of the Clavien-Dindo classification, we see that the increase of complication are most in grade 3 and 4. And this is the good news. We don't have an increase of mortality in revisional procedure in France because it remains in every 0.1%, which means 1 death every 1,000 interventions. So when we stratify in function of the type of revision, this is our main results. You see at the bottom the primary reference, and revision after bending goes up to 4.6, after sleeve it's 8.3, and after bypass 11%. So when we talk about revisional surgery, we talk about procedures that have very different complication rate. And this, you can see the adjusted odds ratio. But then we would like to know something more specifically of what is behind revision after bending, after sleeve. And so we stratified and we checked what happens when we make a sleeve after bending or a bypass after bending. At the bottom, you can see there is quite a big difference. On the contrary, when you operate it after a sleeve, either you do a sleeve or bypass, the difference is not so important. It is much more complicated to analyze the result after bypass because there are a lot of possibilities after bypass. Something quite complex like gastric pouch resizing, something more easy like candy cane resection, and something very complicated like conversion to BPD or distalization. So everything is inside. We could not discriminate between these solutions. Again, we observe an increase of grade 3 and 4 of Clavien. Revision after bypass, we also observe an increase of mortality that went up to 0.3%. So we just make a focus on leak, which is, 2.6% overall, 1.8 in primary, 3.1 in redo after bending, 5.3 redo after sleeve, and 9% after bypass, which means that every time that we operated on after bypass, every 11 patients we had a fistula, which is much more than, for example, colorectal surgery. So obviously we have some limitation in our studies, retrospective, observational, and we lack of some information like I show you for revision after bypass. So the message is the following. We are shifting toward a more complex revisional procedure, and as a complication are a real issue for revisional procedure, probably in the next years we are expecting to observe more complication in revisional bariatric surgery. Thank you for your attention.
We continue with Mina Gerges, thank you. Stage-dependent management of sleeve gastrectomy leaks, a systematic review with proposed classification and management algorithm.
Good afternoon. My name is Mina. I'm from Sydney, Australia, and I'll be talking about management of sleeve gastrectomy leaks, proposed classification system and management algorithm. These are my disclosures. Sleeve gastrectomy leaks, they're a heterogeneous group of conditions in terms of etiology, chronicity, and disease pattern, whether they're a phlegmon, an abscess, or a chronic fistula. And so the treatment should be tailored to that heterogeneity, whether it's localized, lateralized, or generalized, if it's early or persistent, and crucially, if there's an underlying stenosis that's driving the disease process. And all of those variables should be sought out and addressed. So one size does not fit all. Our proposed system is based on CT imaging. So CT imaging is widely available and objective. It's highly sensitive and highly specific. And so we have a type 1 to type 4 treatment algorithm in terms of the different types of sleeve leaks. So type 1 is an inflamed staple line without extravasation of oral contrast and no abscess. Type 2 is an abscess, so if it's a small abscess that's close to the staple line, less than 5 centimeters, or if it's a larger, more lateralized abscess that's greater than 5 centimeters. Type 3 is an uncontained leak or perforation, and type 4 is a chronic fistula, and I'll go into that shortly. This is the pictorial representation of the different types of our classification system. So you can see the type 1 all the way to type 4B. And essentially, this allows us to assess the anatomy, and in combination with the pathophysiology and chronicity, we're able to find the underlying nature of the problem so we can address that and tailor that to that specific patient. And so we performed a systematic review, and the proposed algorithm and recommendations is based on the literature and our experience from a high-volume Australian state-based referral centre. So type 1 is straightforward. It's an inflamed staple line without oral extravasation. So this is intravenous antibiotics, observation, nil by mouth, until they improve, either clinically or biochemically. Ask the patient how are they going. If they're improving, then you can start oral intake early and give them antibiotics. Laparoscopy early on may not find anything, and especially if they get worse, you need to keep in the back of your mind that the staple line can open up and deteriorate over the next 2 to 4 weeks. It's crucial to talk about the stenosis, and this is important in all types of sleeve leaks. It's often misdiagnosed, so endoscopy is quite specific, but is very insensitive. And so one practical test that we recommend is inflating a CRE balloon in the antrum and dragging it backwards. And if it snags on the angularis or gets stuck, then there's likely a stenosis. And it's quite safe to do a pneumatic dilatation up to 30 millimeters at approximately 2 weeks. A 3D CT, as one of my colleagues has previously shown, is an excellent alternative test as well. And until proven otherwise, all sleeve leaks that continue have an underlying stenosis. Type 2A abscesses need drainage, so internal drainage is the best way to go, and we do that by a pigtail drain. Alternatively, a covered stent and external drain is another option. However, that creates a fistula, and so it's not definitive management, but certainly is one option that can be done. And in all cases, early endoscopy is crucial to assess the size of the defect, if there's a stenosis, and the sleeve anatomy, and at the same time you can place an NJT. In these patients, generally speaking, they recover within days and can have introduced oral fluids, and they can be discharged without patient management. Type 2B, this picture is us retroflexing the scope inside a very large abscess cavity. So these are more difficult to treat. Effective drainage is crucial, and the endo-vacuum system has revolutionized the treatment for these. It needs to be placed in and replaced every 3 to 4 days, and within 2 weeks, generally, there's a large improvement in the cavity size, and then there can be de-escalation of treatment. Alternatively, again, an external drain with covered stent has been proven effective in the literature, and TPN is required while they're in hospital. Type 3 is straightforward. These patients need laparoscopic lavage and external drainage. At the same time, endoscopy needs to be performed, and a covered stent is placed. The picture here shows a pseudopolyp due to impaction and decubitus ulceration. And this is what happens if the stent is left in for too long. So these stents need to be removed after 1 to 2 weeks. and then the treatment can then be de-escalated down to what we discussed in 2A, so internal drainage if needed. The chronic abscesses, essentially the main issue here is that there is almost always an underlying stenosis, so this needs to be treated. The 4A's treat it as the previous, so in terms of managing the stenosis, and generally the fistula will get better. The 4B, once all other treatment options have been exhausted, then surgery may be required, and fistula jejunostomy certainly is a better functional option than performing resectional surgery. So essentially, always important to assess the pathophysiology anatomy, whether it's localized or lateralized, the chronicity, the stenosis. Refractory leaks are until proven otherwise, have an underlying stenosis, and that needs to be treated, and it's usually almost always at the angularis. And only after these factors are treated with appropriate minimally invasive modalities, then success can be achieved. We need to tailor these treatments to the pathophysiology and avoid long delays in patients with sleeve leaks. Grazie mille.
Grazie, complimenti. Then we move to Navida Sain from UK. Stage-dependent management of... No, I'm sorry. Sleeve gastrectomy and analysis of patients needing revision for long-term complications.
Hello, good evening everybody, and thank you to IFSO for an excellent meeting and the opportunity to present today. My name is Naveed Hussain, I'm Bariatric Fellow at the Homerton Hospital in London, and I'm going to be talking to you about sleeve gastrectomy complications. These are my conflicts of interest and my case mix. So, as we all know, sleeve gastrectomy was originally conceived as part of a two-stage procedure, and as a standalone procedure has now become the most popular procedure currently for bariatric surgery. And now we need to move to look at long-term complications and rate of revision so patients and surgeons can make informed decisions about surgery. The aim of this study was to identify the incidence of complications following laparoscopic sleeve gastrectomy leading to revision at 5 years, and also indications. So this is a retrospective cohort study. Study period was between January 2016 and March 2018. Exclusion criteria was revisional sleeve gastrectomy and also sleeve gastrectomy performed as part of a two-stage procedure. So in our unit, that's generally patients that have BMI 60 or above. Data was analysed for demographics and reason for revision to referral to revision surgery. So we identified 215 patients undergoing sleeve gastrectomy. 8 were excluded as they were planned for a second stage by the bariatric MDT. Baseline characteristics are as follows: BMI 44.2, 75% female. 58 patients in the cohort, 28% described persistent post-op symptoms, and as you can expect, most of these were reflux, 39 patients. Along with those, there are a few patients with vomiting, regurgitation, dysphagia symptoms, and 20 patients with poor weight loss or weight regain, some of those with some slight overlap with the reflux group. 12 patients with poor weight loss or weight regain alone. From those 12 patients with poor weight loss or weight regain, the mean total body weight loss was 11.5%, mean excess body weight loss was 35%. We defined it as less than 50% excess body weight loss or 20% weight gain from the lowest body weight. For the reflux group, 39% of the patients experienced reflux with or without other symptoms. 3 had reflux pre-op, so it's a 17.4% de novo reflux rate in our cohort. 38% of these patients underwent revisional surgery. 11 were controlled entirely with medication, and 3 had complete symptomatic resolution by themselves. 6 were lost to follow-up. 2 are currently undergoing investigation, and 1 was denied revision by the MDT for non-compliance with investigations. And 1 did not want to be considered for revision. 16 patients overall underwent revision from sleeve gastrectomy, 7.7%, and 15 of those were for reflux, 1 was for regurgitation. Mean time to revision was 5 years, 5.05 years, and median was 5.7 years. Total body weight loss was 20% in this cohort, and excess body weight loss was roughly 50%. So of the 16 patients, most underwent Roux-en-Y gastric bypass, as you can probably imagine. 2 underwent OAGB, which is not a standard practice in our unit. It was a surgeon preference at the time. And 2 underwent hiatus hernia repair only as a planned Roux-en-Y gastric bypass, which was abandoned. So 1 was abandoned for adhesions, and 1 was abandoned due to giant hiatus hernia causing surgical emphysema and difficulty in ventilation. Of those patients, roughly half of them had hiatus hernia, or just over half of them had hiatus hernia identified, and 2 had sleeve kink or stricture at the incisura. Limitations of the study, so retrospective review. One of the major limitations of the study was for patients with weight regain or poor weight loss. In particular, National Health Service, NHS funding criteria does not include poor weight loss or weight regain alone. There's a possibility, and certainly anecdotally, this is a finding in our unit, that patients do actually sometimes overstate their reflux symptoms, particularly in order to access revisional surgery. Therefore, our data might be skewed by the funding model. The other limitation is that 6 patients, not 6%, so 15% of our patients with reflux had been lost to follow-up. Now, we don't know what's happened to these patients, whether they have gotten better by themselves or whether they have sought revisional surgery elsewhere, either abroad or in another hospital. So in conclusion, up to 28% of patients undergoing sleeve gastrectomy have long-term complications. Reflux is the most common complication, and up to 7.7 or possibly more patients proceed to revisional surgery after sleeve gastrectomy at 5 years. Roux-en-Y gastric bypass is the most common revisional surgery, and hiatus hernia is present in about half of revisional cases, with some sleeve kink as well, or incisura stricture. These risks of long-term complications should be discussed with patients preoperatively as part of informed consent, and in particular in the UK for the NHS, risks of weight gain and possibility of revisional surgery. I know in meetings earlier this morning, we always discuss short-term complications, leak, and that sort of thing, but in my practice, very rarely have I seen a discussion of long-term complications, particularly risk of revisional surgery in the future. And in our cohort, the average revision was at 5 years. So that's something to think about. Thank you very much.
Difficult name. At Efata Kalmush. Okay. Early post-sleeve gastrectomy bleeding, is there any changes?
Good afternoon, everyone. I am Abdel Fattah Kalmoush, Al-Azhar University from Egypt. I am going to talk about early post-sleeve gastrectomy bleeding. Is there any changes? Bariatric surgery is most definite treatment of obesity worldwide, and indication of surgery was increased after changes in guidelines. The common procedure done in most of countries is sleeve gastrectomy. Early post-sleeve gastrectomy's complications are bleeding, thromboembolic, and leakage. Early bleeding post-operative is serious and life-threatening conditions. Types of bleeding may be extraluminal in intraperitoneal cavity, or intraluminal, especially after bypass surgery. According to time of presentation, may be early, within 24 hours post-operative, or late after 24 hours post-operative, even maybe chronic up to 1 month post-surgery. Prevalence more common in sleeve gastrectomy. In bypass surgery, it is incidence about 0.9 to 3.9%, but in sleeve gastrectomy, it is about from 1.2 to 5 to 0.6%. And the post-operative bleeding increase hospital stay, increases in risk of blood transfusion, infection, mortality, and morbidity. We have many predisposing factors, especially hypertension, acquired bleeding disorder, liver cirrhosis, thrombocytopenia, type 2 diabetes, and diagnosed gluten factor deficiency. previous abdominal surgery from adhesolysis, old age from atherosclerosis, superobesity, and chronic use of anticoagulant. Incidence according to type of operations, sleeve gastrectomy is higher incidence than bypass, even and the least with bending, and there is no difference in bleeding incidence between robotic or laparoscopic surgery have been reported. Patient may complaining from easy fatigability, shortness of breathing, and signs have tachycardia, tachypnea, and not wait for peritoneal signs, and maybe have hematemesis or melena. Diagnosis and management. Diagnosis of hemorrhage can be challenging. Clinical presentation and time of bleeding will be help in choice of appropriate diagnosis and therapeutic strategies. In some cases, source of bleeding can be identified based on clinical presentations. After suspicion of hemorrhage, close monitoring of vital signs of the patient, hematocrit must be investigated. Don't wait for changes in changes in systolic blood pressure, and to have changes in systolic blood pressure, the patient should be lose about 25 to 40% of his blood volume, and frequent clinical assessment should be made. We have two patients, one is stable patient and the other is unstable. In stable patients, we immediate resuscitation and backed disease transfusions, and anticoagulant should be stopped, and the platelet transfusion may be needed, even adequate platelet count, and obtain coagulation tests. In unstable patients who have hypotension, severe tachycardia, and drop in hematocrit value, indication for urgent surgery. Urgent surgery, our rule to have identify the source of bleeding, stop it, and remove any blood clot from intraperitoneal cavity, and immediately resuscitation by fluid and blood products. Management can be done laparoscopic or laparotomy, but laparoscopic may be relative contraindication in severe hypertension. Prevention is more better than treatment by good preoperative assessment of the patient. Routine elevation of the blood pressure intraoperative and during stapling. Considering reinforcement stable line in sleeve gastrectomy and use correctable stable height for given tissue is the most important factor for this prevention for this complication. This study, retrospective study conducted on 1,752 patients from 2016 to 2022, divided in two groups. First groups, our strategy was to put just clipping on the stable lines, as seen in the pictures. But in second group, which is our strategy, that we mandatory elevate blood pressure above the normal level of the patient, about 324 30 millimeter mercury, overseeing or buttressing of the stable line, putting clips on the greater momentum at the beginning of the blood vessels, especially at the short gastric blood vessels, retain the position of the table to decrease our more congestion at the side of the stomach, and decrease intraperitoneal pressure to 14 or 12 or to 14, and closure of the portal fascia by the port side by fascial closure. That picture shows that our routine after reinforcement of the stable line, and that's after clipping on the greater momentum. That's a video, short video. That's routine. Our patients just starting by reinforcement at the angle of the head, and even can we fix this angle of the head to the left crest of the frame if we have wide hiatus. Continuous our reinforcement to reach the end and both clips and closure, but I'll skip this video to save time. There is no significance between both groups as regard demographic data, age, BMI, and comorbidity. In first group, we have 17 cases of bleeding, 5 cases need re-exploration. Most of these cases have there is hypertension is predisposing factors. And second group, there is marked decrease in the incidence of bleeding. Just have 5 cases and 1 case need for re-exploration, and the bleeding come from the greater momentum. Length of hospital stay about 4 days. 1 case need for readmissions, and there is no mortality. That's picture of the bleeding. That's short video. Okay. discussion that the post-operative bleeding is certainly most common complications that occur in the first 24 hours. Its incidence may occur up to 16% of the patients. Early detection post-operative bleeding is very important. Conservative management may be in mild cases. Early return to operative theater and laparoscopic exploration is very important in helping early diagnosis and decreased risk of blood transfusion, length of hospital stays, and the return to normal life. Our conclusion that early bleeding post-gastrectomy have different presentation and may be life-threatening condition. Early detection and the re-entry of the operative room is very important and decrease mortality and morbidity. We can't reach zero complication, but we can decrease its incidence. Thank you.
Now we go to a colleague from China, Yuntao Nia. Development and validation of non-normogram for predicting anemia 1 year after bariatric surgery. Analysis from multicentric cohorts.
Hello everyone, I'm Yuntao Nia from China Japan Friendship Hospital, Beijing, China. My topic is development and validation of a nomogram for predicting anemia 1 year after bariatric surgery. Analysis from multicentric cohort. I have no conflict of interest. Anemia is one of the most common nutritional complications after bariatric surgery, prolonging hospitalization and increasing all-cause mortality. The incidence of anemia ranges from 12 to 60% 1 year after sleep and RYGB, but more and more evidence has shown that post-operative nutritional supplementations recommended by the current guidelines is insufficient to reduce the incidence of anemia. So, screening patients with a high risk of post-operative anemia is of the most important to facilitate enhanced surveillance and appropriate nutritional supplementations. So we aimed to develop a nomogram for predicting anemia 1 year after bariatric surgery. Patients treated in our hospitals from September the 27th to March the 2022 were reviewed. And to construct the training cohort. 14 variables, clinical variables, and 24 laboratory variables were collected. And anemia was diagnosed according to the WHO criteria. Univariate and multivariate logistic regression was conducted to develop the nomogram. Yeah, and an independent validation cohort from Xiangya Third Hospital that comprising 64 patients was used to externally validation. Yeah. This is the patient characteristics of the training cohort. A total of 318 patients were in the training cohort, and the total incidence of anemia was 39%. This is the laboratory characteristics. Yeah, after the univariable logistic regression, 13 variables were selected and was considered associated with the post-operative anemia. Combined with several factors such as age, anemia-related nutrients, 15 variables were included in the multivariable logistic regression. And finally, 5 variables, age, surgery, type, folate, vitamin B12, and hemoglobin were predictors for the post-operative anemia and construct the nomogram. And this is our nomogram. The AUC was 0.8, indicating that the model has excellent discrimination. And under the yield index of 0.343, the sensitivity was 0.832. The specificity was 0.674, and the accuracy was 0.736. The calibration curve showed that the calibration is very good, and the decision curve analysis showed that it has a great clinical utility. Yeah, and next we examine our nomogram in the validation cohort, and this is the patient characteristics of the validation cohort and the laboratory characteristics. And the AUC maintained at the 0.815 confirmed the discrimination ability of our nomogram. And the calibration curve and decision curve analysis also indicated that our nomogram has great calibration and clinical utility. We have also integrated our nomogram into the web-based version so that the clinicians can easily predict the probabilities of anemia just by clicking on your computer. So to draw the conclusion, our study developed and externally validated the first nomogram for predicting anemia 1 year after S3 and RYGB. The nomogram showed excellent discrimination, calibration, and clinical usefulness in both training cohort and external validation cohort. And third, the web-based nomogram can conveniently assist the clinics screen patients at high risk for anemia after bariatric surgery for early intervention and enhance the surveillance. Thank you very much.
Amir Obeid, alimentary leaf obstruction following one anastomosis gastric bypass, a rare case and literature review.
Hi, good evening. My name is Amir Obeid. I'm a surgical resident at the Nazareth Hospital in Israel. I'm in my final year in residency. I'll be presenting about alimentary limb obstruction following one anastomotic gastric bypass, a rare case, and literature review. I have no disclosure. These are the past surgeries which we have done in the past year. So as you all know, despite advancements in surgical techniques and technology in bariatric surgery, there remains an ongoing complication rate, which remains a challenge for surgeons despite these advancements, and various complications that can lead to post-op abdominal pain, which cause gastrointestinal impairment, such as bowel obstruction, usually seen after Roux-en-Y gastric bypass. Our objectives of the study is which we describe a case in which bowel obstruction of the alimentary limb following one anastomotic gastric bypass as a result of V-lock suture, which caused the obstruction of the alimentary limb. And after literature review, we found that only a few descriptions have been reported which were seen after Roux-en-Y gastric bypass and not one anastomotic gastric bypass. The aim of the study, as I mentioned, was to compare these cases. So our case report was a 43-year-old woman who underwent mini gastric bypass 2 years prior to 2023 in a different institution. She had also a cholecystectomy 1 year prior to this, and she had repeated admissions to the emergency department with complaints of ongoing abdominal pain and vomiting, and they were ongoing, and despite this, she was only treated with analgesics in different institutions and discharged every time. But upon her final 2 admissions to our institution, she underwent an abdominal CT scan and gastroscopy, which both were normal. The CT scan didn't have any pathological findings, and the gastroscopy showed no signs of marginal ulcer, and had normal gastric tissue. And upon her last arrival to the ER, she had worsening symptoms of abdominal pain and vomiting, and she had abdominal tenderness without signs of peritonitis. Despite this, all her lab tests were normal. We decided to perform abdominal CT, which showed suspicious signs of internal hernia. So after this, we concluded that she needed a diagnostic laparoscopy. As you can see in the first illustration at the top, you have lymphatic fibrous tissue which formed due to this chronic obstruction. As you can see, the V-lock suture, which was attached to the antrum, which attached the alimentary limb to fixate it, which this, just to state that this was performed in a different institution as well. We performed release of all the adhesions, the fibrotic adhesions, as well as the obstruction. As you can see in the top picture is the antrum. We closed this after finishing the discharge of the obstruction and released the V-lock suture. The patient was discharged post-op day 2 with no complaints, and she was followed up in the outpatient clinic for 1 to 2 years, and she continued normal diet with no complaints as well. So after literature review, we only found 5 published cases which reported V-lock suture obstruction in Roux-en-Y gastric bypass and a couple other of gastric bypass surgeries. discussion, internal hernias, which are a rare but serious complication of gastric bypass surgery with an incidence ranging from 0.2 to 9%. And today, CT scan, which remains a diagnostic tool to diagnose internal hernias and other types of obstruction following bariatric surgery. This patient, in our case, had a VLOC suture which obstructed the elementary limb following mini gastric bypass, one anastomosis, which can lead to formation of obstruction and types of internal hernias. Few studies have reported an increased risk of internal hernias with the use of VLOC sutures in gastric bypass surgery compared to non-absorbable sutures. A retrospective study also, which we found, had the use of VLOC suture and it was associated with a higher risk. So all in all, despite these advancements, complications still remain an issue for many surgeons, which can cause abdominal symptoms following laparoscopic bariatric surgery, and they continue to be a challenge. Overall, our study adds to the existing body of literature on complications in bariatric surgery and highlights the importance of ongoing research and innovation in this field. And also to add whether or not it is necessary to perform suturing of the elementary limb and fixating it to the antrum upon concluding the bariatric surgery. Okay, thank you.
Dr. Ong from Singapore. High-resolution manometry is a valuable tool in the investigation of adverse symptoms in post-bariatric patients.
Good evening, everyone. I'm Marcus, and I'm a junior doctor from Singapore. Today, I'll just be presenting on manometry in post-bariatric surgery patients. So many patients, as you know, experience adverse symptoms at some point following bariatric surgery. Investigation for the cause of these symptoms include endoscopy, radiological imaging, and more recently, physiological studies such as manometry. However, the value of manometry in such a setting has not really been well defined. Our aim is to clarify the utility of manometry in the assessment and evaluation of symptomatic post-bariatric surgery patients. So this is a retrospective review of 80 post-bariatric surgery patients with adverse symptoms such as reflux and dysphagia in a single bariatric practice over a 9-year period. And these patients have undergone anatomical studies as well as high-resolution manometry. Subsequent surgical procedures were also recorded if there were any. So high-resolution manometry was performed with up to 10 liquid and semi-solid swallows, and parameters such as distal contractile integer, lower esophageal sphincter pressures, intragastric pressures, and bolus clearance were recorded. Our patients were also stratified according to the Chicago classification. So 80 patients were included in the study, with 81% being female and 19% being male, with a mean age of 54.5 years. There were 18 post-gastric band, 31 patients post-sleeve gastrectomy, and 31 patients post-Roux-en-Y gastric bypass. So we grouped them according to symptoms as well. 48% had reflux, 34% had dysphagia, and the remaining 15 patients have other symptoms. So in our manometric study, 65% of patients actually had positive findings, with 41% having some form of esophageal dysmotility, according to Chicago classification. 22.5% had hiatus hernia. There were also some patients with hypertensive and hypotensive LS mean, as well as high or low DCI as indicated. Our study also tried to stratify the intragastric pressure. We took less than 20 millimeters of mercury as normal, 20 to 40 as elevated but still normal, and then anything above 40 as severely elevated and pathological. So the percentages of patients in each category are as follows as well. There are also 7.5% of patients with more than 50% incomplete bolus clearances. 90% of our patients had endoscopy done, with 44% showing positive findings in endoscopy. 15% of these patients has reflux or esophagitis, with 9% having grade B and above. 6% have hiatus hernia, and the remaining patients have dilatation as well as gastric stenosis. 70% of our patients have radiological imaging done. This includes like CT FIS as well as barium or gastrografin swallows. So 55% of our patients has positive findings, including 20% with hiatus hernia, as well as other findings as well. So when we combine the two anatomical studies, a total of 61% of patients have abnormalities found on their anatomical studies. So we did a correlation between manometry and anatomical studies, and we came up with this table above. So as you can see, as previously discussed, 65% have abnormality in their manometry, 61% have abnormality in their anatomical studies. What's more interesting is that of 53% of patients with normal manometry actually have abnormal anatomical studies, and 58% of patients with abnormal manometric findings actually were previously normal anatomical studies. There was also a high correlation between abnormalities found in both types of studies as well, with 34 patients. If we included intragastric pressure in our study, these numbers were more significant. As you can see here, there's an increase in sensitivity for manometry in detecting abnormal findings in previously normal anatomical studies. The correlation for abnormal findings in both types of study also increased. There is also if you combine both anatomical and manometric studies together, you actually get a diagnostic yield of about 84%. And if you include the intragastric pressure, this increases up to 94%. So 53% of our patients have further surgical procedure done, with 44% conversion to Roux-en-Y gastric bypass, and 14% having hiatus hernia repair, while the remaining 18 patients had other form of surgery done. So on conclusion, endoscopic and radiological investigation do establish anatomical abnormalities, but is of a lower yield of abnormal findings. However, if you combine both manometry and anatomical studies, you actually detect abnormalities at a much higher rate. Hence, we propose that manometry actually serve as a useful adjunct in detecting functional disorders which other investigation may miss. So this is the algorithm that we propose. Thank you.
Anna, any questions?
I don't have any question, but I will summarize a little bit of all the presentations. Follow-up remains something that cannot be discussed, and we should try to reinforce with the patients that they should maintain their follow-up to avoid complications in the long term. Usually they are not present in the short term, but for in the long term. And attention should be paid to all the technical aspects of the construction, either of a gastric bypass, a sleeve gastrectomy, or OJB, to avoid complications that we can see because of the surgery performed not technically correct. So that would make a difference and would avoid a lot of complications of cases that were presented here. Revisional surgery will continue to grow because more patients have surgery. We have change in definitions in obesity as a chronic disease. So in the long term, the patients will need other interventions. So revisional surgery would be raising and probably will be a big part of our practices in the future. And endoscopic will take a big a difference in the management of complications. So we need to work with endoscopic, and surgeons should be trained better to deal with complications endoscopically. So it was great presentations of all of you.
Thank you, Anna. Thank you for your precious conclusions, and I definitely agree, of course. We are closing in perfect time. Thank you to all presenters for staying in the time assigned. Thank you so much.
Thank you.